I take pleasure in inviting the next speaker for the day, Professor Annie Heiderscheit, PhD, MTBC, LMFT, is a professor of music therapy at Anglia Ruskin University in Cambridge, United Kingdom, and director of the Cambridge Institute of Music Therapy Research. Dr. Heiderscheit is a board-certified music therapist and has significant clinical experience working with critically ill patients and their families across the lifespan. She has over 30 years of clinical experience as a music therapist and over 20 years of experience as a music therapy educator. She has published extensively on her clinical research, clinical work, and the music therapy education and training. Welcome, ma'am. We are looking forward to hearing from you.
Oh, there's it. Okay. Can I use the lavalier mic? Is that possible? I tend to move around. Good morning. It's wonderful to be here with all of you. I'm gonna put on the lavalier mic because I tend to move around. And knowing that about myself, I want to, I want to make sure I don't lose sound on this stationary mic. And I'll make sure I don't set it off too. Perfect. Great. Can you hear me okay? Wonderful. Let me just, can I use this one? Yes, I can. Okay, thank you. Today I'm going to focus on music therapy and music interventions as a resource for health and well-being, specifically in mental health and medical care. I do want to start by saying thank you. Thank you to the Institute and all involved in planning this conference. It's an honor to be here and to share in this exchange of knowledge. I am naturally a very curious person. I love learning, and that means the opportunity to learn from each other in this process. So it's a tremendous honor to be here and share this time with all of you. You will probably notice while it says I'm from the UK, I do not have a British accent. That is because I've only been there for a year. I spent much of my career practicing, doing research and teaching in the US. So I am new to the UK. And my family just arrived there 2 weeks ago, and they are unpacking the shipping container while I am here. So I'm looking forward to everything being unpacked. I'm really trying to manage that expectation, actually. Before I begin, anything that I do with regards to research cannot be done without collaborative partners. So I want to just honor and thank the collaborative partners that I've had the opportunity to work with over the years. Research is a team effort. And so that means collaborating with lots of people to make all of this research happen. So I want to honor those collaborative research partners. And I also, hold on, let me go back. I also want to acknowledge the research team that I have the great fortune to work with at the Cambridge Institute for Music Therapy. These are all the wonderful researchers that I am blessed and honored to be able to work with and collaborate with on an ongoing basis. So with that, let's see if I can get, there we go. With that said, I want to really explicate my view of the world because that informs how I do research, how I do clinical work. So what I have come to believe in these over 30 years of doing clinical work and the over 50 years of living in this world as a human is that our world is complex. But music and music therapy hold potential and capacity to address challenging issues as well as symptoms, and that those can foster health and well-being. And I wouldn't be doing what I do at this point in my career if I didn't feel and believe that to my very core. So I want to just clarify that's where this research really stems from, is from this very belief. So because music is a resource, we can use it in our everyday health and well-being, and not just when we have something in our life that might be a diagnosis or something that's been pathologized, but to foster and support our everyday health and well-being, and that music can be an agent of change for us. So what I'm really going to focus on in our time together is how we can use music and music therapy to address some of the very complex issues that patients and their families are facing in healthcare. And I'm going to do that through some of the research that I've done and exploring some of those really complex issues. And I want to start with a call that I got one day from Dr. John Wagner, who was the director of pediatric oncology at the University of Minnesota Masonic Children's Hospital, was a researcher, leading researcher in pediatric oncology. And he called me one day and said, I wonder if you have time to meet. And I said, absolutely. We scheduled a meeting. I went to his office. I sat down and he said, I have to tell you that I'm afraid in all of my efforts in looking for a cure for cancer, I have left my patients suffering. And in that moment of hearing that, I could feel my heart ache for him and how difficult it had to be to come to that realization. Here he was in all of his good efforts, looking for a cure for cancer to make his patients and their families' lives better. But now recognizing in this challenge of looking for this cure, they were still left struggling and suffering. That could not have been an easy realization to come to. And his next words to me were, can music and music therapy help? And of course I said, absolutely. Now, he was specifically looking at patients, pediatric patients undergoing bone marrow transplant. I'm not going to go into a deep dive into bone marrow transplant, but just know that it is an aggressive curative medical procedure and process. And by aggressive, I mean very aggressive. In essence, the immune system needs to be destroyed for new cells to be introduced into bone marrow. So if you can imagine how difficult, how complicated it is for an immune system to be suppressed, for new marrow to be introduced, it is not without significant challenges and side effects. So bone marrow transplant is not just used for people diagnosed with cancer, it is also used for non-cancerous diseases as well. So we can see a variety of the types of individuals that undergo this process. But understanding the experience of the transplant process, and we have to understand this is a curative process, but I think it's important to understand that even in curative processes, we are causing challenges and it harms patients as well. So we need to understand and hold that together. So patients are not only hospitalized, but they're confined to their room for 35 to 40 days. I think we have a new understanding of that, having come through the pandemic, what it's like to be isolated and restricted. And we know isolation has a serious impact on our health and well-being. They experience emotional and somatic distress, not only from the isolation, but all the physical symptoms they experience as a result of this treatment process. The physical symptoms then are conversely complicated because of their diminished emotional well-being and their lack of social engagement. So it's creating this unfortunate perfect storm of lots and lots of challenges for them. I will not read through all of these physical and psychological symptoms, but when you look at these and recognize these are what they're experiencing, this is a very difficult and challenging process. And then, you know, nobody would want to experience this, but we're talking about a curative, life-saving measure. So the intervention that I designed was really designed after a patient-controlled analgesia protocol. So if you are not familiar with that, if you can see in the picture, the patient is controlling their pain medication pump. And what we discovered in that research, and what that research tells us, is that when patients are able to control that, they actually use less medication. When they're in control and they can control that, they're using less medication, right? So they're able to detect, respond, and they're finding that sense of control, they need less medication. So because these patients are hospitalized 24/7 for over a month, and as a music therapist, I can come in maybe once a day, that's not enough. That's something, and that's very valuable, but it's not enough. It doesn't put them in control. So part of what I wanted to look at and create is how do we put them in control at a time where they have little to no control in their life. So conceptualizing and designing an intervention that empowered them was key. Developing resources that would support their engagement was also key. Providing them education and support as a music therapist to help meet a variety of needs was key in this process. And then giving them instruments that were accessible and they could engage with, which means it didn't require previous music training, was important, right? There's a lot of complexity here. How do you make all of these things happen? These are challenging. So I became familiar with an instrument called the Reverie harp. It was designed by a music thanatologist in Australia and built by luthiers in Minnesota, which is where I lived in the Twins in Minnesota back in the States. It's a lap harp, but you can strum it openly and it can be tuned in a way that you can just play this openly. So it could be tuned, you can just strum it and you're going to get this beautiful aesthetic sound. Again, requiring no musical experience. You can also play it with mallets like you would a hammered dulcimer. So it was easily accessible to patients and families. I also provided them a variety of other instruments, shakers, drums, rhythm instruments, so they had other instruments to utilize, created song sheets that could be utilized with the Reverie harp, and then the song sheets kind of showed dots on there so you can pluck out a melody to a song. And I also developed play-along tracks that were uploaded into what is called the Get Well network within the hospital. It's a digital platform where they could access all of these resources. So the protocol, again, was really to empower patients and their families. So it was a patient and family directed protocol designed to allow them to choose when, how long, and how often they wanted to engage in making music. So all of that control was put into their hands. What they were then asked to do is each time they engaged in making music or had a music encounter is to just journal about that. So I had some data to understand. I then visited with them each week to pop in, meet with them, tune the harp, see if they had any questions, and just provide any additional information that they might need to support their engagement. So I mentioned a moment ago the Get Well network, and that is a digital platform. And you can see here on the matriculated arm that can pull bedside, right? They can access all these resources as well as many other hospital resources. But you can see in the other picture up on, there's a big screen TV, and all of the rooms in the children's hospital are individual rooms, and they are designed for patients and their families to be there. So oftentimes when children are hospitalized, their family wants to be with them. And so they're individual rooms where patients and families can stay together. So they can access all the resources that I developed for them via the Get Well network. So just an overview of the patients involved in the study. They ranged in age from 9 to the age of 12. Were hospitalized anywhere from between almost 30 to, up to 46 days was enrollment in the study. I'll encourage you just to take a look at all the family members that participated in the study. This ranged from parents to siblings to grandparents. So they were making music, not with just parents, not with just siblings, but grandparents involved as well. So one of the things that I looked at from their journals is looking at why were you engaging in making music? I'm not going to read through all of these, but you will see a lot of different reasons. Lots of different reasons why they were using music, and then who was involved in making music based on what they reported on their journal entry forms. So in analyzing that data, all of those 121 journal forms, there were themes that emerged. So I conducted a thematic analysis, and what I discovered in that is these three major themes. One was choice. I had a choice to make music. The other was I could use music as a resource. And the third was a sense of empowerment, being able to exert control, my sense of agency in that process. And the bullet points that you see here are the sub-themes that emerged within those. So being able to decide when I wanted to make music, that was my choice. How I could manage symptoms, that was my choice. Different ways I could engage with music, that was my choice, right? And music being a resource, it was accessible to me. Discovering I could make music.Maybe I didn't see myself as a musician, but I could make music. And it helped provide a means of being able to cope with what I was going through. So these were the themes that emerged. I'm not, for the sake of time, I won't go further into all of these. But what is interesting to me is we consider all of the different needs being addressed, different family members playing together. So a patient is going to have very different needs than their family members in that moment, because the patient is the one undergoing the bone marrow transplant, experiencing all of those really difficult symptoms. But family members are a part of that process, and they're having their own experience. And so there are different needs happening simultaneously. And making music was able to meet these diverse needs simultaneously. Now, when I talk to my research colleagues who are in other disciplines, they go, wait a second. You're addressing multiple needs simultaneously. Yes, music can do that. That is an important part. And what I really want to highlight in this, that music is an agent of change. And while someone or their family might be engaging in a music experience together, different needs are being addressed in that moment. So I want to just share a quick example from this particular study. The study was conducted at the University of Minnesota, specializes in bone marrow transplant, which is a very, again, complex and unique process. So we have patients and families from around the world that come there for treatment. So Jose and Miguel were there from South America. Jose, the father, traveled with his son to Minnesota for the treatment, and the rest of the family was still in South America. When they were approached about this study, Jose said, listen, I'm not musical. I don't really know anything about music, but I'll try. I'm willing to try. So, and in one of my weekly visits with them, he shared that a recent struggle. He came, Miguel was really, he said he was very irritable and cranky, and everything I tried, nothing worked. And I didn't know what to do. I was feeling desperate. I happened to look over and I saw the harp. I just grabbed it and I started to play. And he said he just played and he kept playing. And he said, eventually I noticed that Miguel fell asleep. And I was so relieved. And then he said, I didn't realize that I needed that music as much as Miguel did. Right? He was so focused on meeting the need of his child, right? Which is what we do as parents. We need to meet that need. We need to take care of them. But once Miguel was sleeping and relaxing and more peaceful, he recognized I needed that too. And his need was maybe quite different from Miguel's in that moment, but both of those needs could be met from the music. So I want to talk, now we're going to shift gears a little bit. I want to talk a little bit about working with very critically ill patients. And a study that I've been working on with colleagues in the States is looking at the use of music listening to address delirium. So delirium is this state of acute confusion that can occur for a number of reasons. It can happen when people have dementia. It can happen when there's an infection in the body. It can happen when there's sleep deprivation. It can happen as a result of medications. There are many, many causes, but we don't have treatments for delirium. And what we do know is when someone experiences delirium, their health outcomes dramatically decline. So we need treatment for delirium. So the research study that we just concluded recruitment for was a 5-year randomized controlled trial. But what came before that study was a randomized controlled trial that we implemented music listening with mechanically ventilated patients. And what we found in that study is that music had a significant impact. Again, this was a patient-directed music listening protocol. So this is what funding agencies have a really difficult time accepting, because they don't want the patients to be in control. And in this study, the patients were in control. Again, it was designed after patient-controlled analgesia. The patients chose what music they wanted to listen to. It was their preferred music, which means not everybody's listening to the same music. It means they're listening when they want to listen to the music, how often they want to listen to the music. It's completely their choice. So that's what this initial study was based on. And what we found in that study is there was a significant reduction in their anxiety, a significant reduction in sedation exposure, as well as intensity and frequency, which means they required less medication. And then what we looked later on with that is there a cost reduction when we can reduce the amount of anxiety and medication, which there is. We can reduce costs of care. So that led us to begin to wonder, can we do something about this very persistent and difficult symptom of delirium? So that's where we went next. So we know that while our study is focused on mechanically ventilated patients, we know that delirium occurs across different clinical settings. And so the thing that's going to be interesting to me, and I was just in Norway talking with teams about how do we address the problem of delirium, because it's a significant issue and it's going to continue to rise the costs of healthcare, and we need to address this. So if you just look at these numbers, even 10 to 15% of patients that come into the emergency department are experiencing delirium. 33 of geriatric patients, 50% that get a hip replacement or cardiac surgery, 75% that are mechanically ventilated, and 85% in palliative care. Those are significant numbers. We cannot ignore this issue of delirium. So because we know that it is a difficult, challenging symptom to address, and there is no pharmacological or no non-pharmacological treatments for delirium to date, music holds potential. So what we're seeing in the current emerging research, and it's just emerging, is one of the brand new PhD students, she just defended her PhD last week in Norway, was utilized live and recorded music interventions to manage delirium symptoms in geriatric patients, did a feasibility study. Had done some systematic review looking at that, which helped to inform her interventions in that study. And the team that I've been working with is using a patient listening protocol. We just finished a 5-year randomized controlled trial, which started right before COVID-19 hit, and certainly disrupted our study, which was in the ICU, because every ICU during COVID was filled with COVID patients. So we had to stop enrollment at that time. But it's concluded and we're doing the data analysis now. So while I don't have data to share with you, it will be forthcoming, and excited to share that with you. But we're seeing this research begin to emerge around the world. And it's a much needed area to address because it is a significant issue within healthcare across clinical settings. So this particular study involved physicians from Indiana University Medical School, nurse researcher from Mayo Clinic, myself, and again, it was funded through the National Institutes of Health, and we are just in the process of analyzing the primary data. So I'll keep you posted of that as we get that. But the protocol, again, designed for patients to be empowered, listening to music that's between 60 to 80 beats a minute. The music was curated so that the tempo is moving from 80 beats a minute down to 60 beats a minute. So there are not sudden shifts in tempo, in key changes, or instrumentation. So the music's been curated to ease the music listening experience of the patient. We also have a biomedical engineer who's designed an app for us so we can track what patients are listening to, what music they're listening to, when they're listening, how long they're listening, and it records each piece of music. So it's allowing us to really gather the granular music data as well. So that's a very unique part of this process too. So to date, we've enrolled, and our aim was 160 participants. I can tell you, we probably screened nearly 15,000 patients to get 160 mechanically ventilated patients enrolled in this study. So it takes a long time to do that research. We have 3 months, 6 months, and we've got 12-month data that will be a part of this study. And the primary and secondary outcomes are looking at delirium, anxiety, and pain. And so as we get that primary data analyzed, then we'll begin to look at all of that music data. So there will be many publications coming out of this particular study. But again, addressing one of the most difficult and complex symptoms that we're experiencing in healthcare. Now I want to move over into the mental health. And really, to me, one of the bigger challenges is not just looking at how we identify, diagnose a mental illness, but are we addressing the underlying issues that are causing that? So I did a research study with individuals in eating disorder treatment. I've spent a significant part of my career working with individuals in addiction as well as eating disorder treatment. And these are very complex disorders. They're complex for a number of reasons. So as we look at eating disorders, they're complex because there are other comorbid mental health diagnoses. There are physical and medical complications that impact every system of the body. There can be prolonged and multiple treatment episodes. The average time and length to recovery is 7 years for someone with an eating disorder. There are multiple etiologies and risk factors, and we're seeing an increase in incidence of eating disorders around the world. I think this number is staggering. 66% increase in hospitalizations in 2020. 66% is unbelievable. And what's estimated to date is the treatment is effective for 50% of clients. I think that's not good enough. If it were my son or daughter, I would say that's not good enough. We should be doing better. So I was curious in my own clinical practice. This study really was founded from my clinical work, because what I was noticing in my clinical work when I was working with clients is there's something happening as we're getting into some of this deeper psychotherapeutic work. And I'm trained in the Body method. And as I was doing some of that work with some of these clients, I began to notice there's things shifting and happening that wasn't happening in their other therapies. So it made me rather curious, and I decided to move forward with a feasibility study and doing this into other aspects or other treatment or levels of care with an eating disorder treatment. Those of you that aren't familiar with the Body method, it's using very programmed classical music in which the client is imaging but we're having an active dialogue in that process. So they're describing to me what they're experiencing, and I'm asking questions to help deepen their experience in that process. So the study was based on this conceptual framework, which was the foundation of my doctoral research working with adults in addictions treatment of we need to address the underlying issues, right? So whether that's trauma, whether that's there's unhealthy coping strategies because of unresolved issues or unresolved emotions or issues with relationships, we need to address those. What I was finding in working with clients and doing some GIM, that we were able to do that. And as we were able to do that, I was seeing anecdotally that things were changing. They were better able to cope. They were better able to manage in their life. So I wanted to explore this a bit more. So the study took place over a 12-month period. Participants overall received 116 GIM sessions, which was an average of 14.5 sessions, with a range between 11 to 17 sessions for participants. The study involved 8 females between the ages of 22 and 58. They had various eating disorder diagnoses, as well as multiple comorbid mental health diagnoses. On average, they'd been living with their eating disorder for 15 years. It's a long time that they've been dealing with this. And a mean of overall 8 previous treatment episodes. This group was engaged in various levels of treatment, so they weren't all in the same level of treatment. So you can see here, you can see their eating disorder diagnoses. But again, if you go to the next column that looks at their comorbid mental health diagnoses, their eating disorder was not the only issue. And so you can see for some, there are 4 additional, 3 additional, 2 additional. These are very complex cases. And you can also then see how many previous treatment episodes they had had. So when we're treating a whole person, we can't just say, I'm just going to look at this part of you, oops, sorry, and then not look at these other parts of you. So when you're working with someone, all of these come into play. It's not just their eating disorder, because these other pieces are contributing to their eating disorder. So the protocol was, this was a feasibility study to really see, can we integrate this into the usual care and eating disorder treatment? We wanted to look at what do participants identify as their perceived benefits of GIM? What are the challenges of integrating this into eating disorder treatment? And so participants received 1 session per week during their usual eating disorder treatment. You can see on kind of the scale of helpfulness, which is kind of a Likert scale, that and it went from 1 to 7 on average. They rated it a 6.5, which 7 was most helpful, but it ranged between 5 to 7. So they experienced it, identified it as being helpful in their process. Here's what they found helpful about it. This was an analysis of their feedback about these sessions. It helped them develop insights, and that led them to finding inner resources, connecting to their courage, discovering their own resilience and their sense of empowerment. It helped them with emotional processes. So identifying their emotions, which they had kind of cut themselves off from, exploring and working through unresolved emotions. And it helped to foster support and growth. So being able to begin to utilize those inner resources, see oneself as capable, envision their life without the eating disorder, and to begin to feel comfortable with the changing self. So beginning to feel a sense of comfort of living life without the eating disorder. Again, when you look at they've been, living with this for over 15 years. Imagine shifting that. So I also did a thematic analysis of their transcripts of their sessions. And these are the themes that emerged. So there was the emotional landscape, which looked at initially that feeling a sense of being stuck, then acknowledging those emotions and working through unresolved and difficult emotions. There was a theme of relationships, and that dealt with relationship to self, others, as well as the eating disorder. And then the theme of transformation and growth, finding strength, experience healing, and feeling empowered. And the next thing that I did was an intertextual analysis. So this is really a humanistic and conceptual frame that puts the emphasis on understanding the text, so they're transcripts from the imagery, and putting the individual at the center of that. So understanding that within this individual's context. And what I discovered in the analysis, this intertextual analysis, was it's really an understanding of the therapeutic arc. So the arc of their therapeutic process. And that arc aligned with the hero's journey. If you've ever watched a movie, read a story where someone is engaging in a process and they go through struggles and they come out stronger, thank you, that is the hero's journey. We see it in many movies, we see in many narratives, but that is what their therapeutic arc aligned with, was this hero's journey. So I'm going to move from this for the sake of time. Because to me, it's important to understand the implications from a neuroscience perspective. What we know from neuroaesthetic research is the power of aesthetic and creative experiences, that the embodied engagement with emotions and memories, it fosters a deeper explanation through our various sensory modalities. When we can externalize, for example, I can image, right? It allows me to build and develop my capacity to explore that, because I can create some psychological distance from that. And when I can do that, I feel safer to process unresolved emotions and trauma, right? I can choose that level of distance. Additionally, the symbolism and the metaphor that is represented of the eating disorder engages our cognitive and emotional processes, which became pivotal moments for the individuals as well. So there's exciting things happening from a neuroscientific level that we need to do more research on. We need to do some more mobile brain imaging of this process to better understand, but it's also very exciting to begin to bring these areas of research together. So I want to close with, the world is taking notice of the capacity and power that music has. And as a music therapist, and any music therapist out there, anyone who is empowered in using music, we have the ability to prepare and support the world to not only understand, to learn, but how to use music as a resource to meet a myriad of needs. So I won't go through this, but this is a music-based intervention toolkit that the National Institutes of Health has developed. And they're calling for broad systematic exploration of music therapy and music-based interventions. So if we don't think the world is watching, the world is watching. The world is paying attention and curious to know more. And we are situated to do that. So if we think about that, we can meet a myriad of symptoms and diverse symptoms simultaneously to help. We can uncover and address underlying issues that foster recovery. That engaging in this aesthetic creative experience engages the brain and the body to support therapeutic processes and people's recovery. And we can also do that by demonstrating an economic benefit. Those are significant. So we need to, I don't know where there's supposed to be a think there, think big, and we need to be bold in the research that we do. There it is. I'm not sure how it came in like that, but it just seemed to do that. We need to be bold in not only the aspirations, the opportunities that we seek, the risks that we take, the advocacy and education, and engaging in robust research. But we will do better when we do this together and not alone. So I wanted to end with this lovely quote from Aaron Antonowski because I have woven his theories and work into my own research. So I think this is just a powerful statement. If we are coming to understand, I think those of this room are already there and know this. Health is not an absence of disease, but rather a process by which we maintain our sense of coherence and our ability to function in the face of changes in ourselves and in our relationships and in our environment. So thank you for the opportunity to be here. Is there time for questions or do we need to move on? Is it okay? I think I got that stuck. Oh, and I'm still attached, aren't I? There you go.
Hello, ma'am. Your talk is very informative, and I am having one question.
Yeah.
What is the cost of this instrument, ma'am? The Reverie
Harp?
Yeah, Reverie harp.
So there's two options. The music makers who build, you can buy a kit where you put it together, which I think is about maybe 250 US dollars, or you can buy it all put together, which I think is just a little over 500 US dollars. Yeah. So there's a couple of options. I would like to yeah, is there something similar? Yeah, wonderful. Great. Yeah.
Okay. It is available here, ma'am. It is available in online or how to
Yes.
buy
So
it?
if
How
you
to
go to
purchase?
Music Makers is the
Okay.
company, and they have built it. Their luthiers make it. They will put the kits. They have the kits. So if you wanted to put it together yourself, they can ship. I have no idea what the shipping cost would be. Probably so
That's
much
fine,
more than
ma'am.
we'd want it to be. Yeah, I would love to just get them here. And one of the questions I haven't asked them since I've moved to the UK is, can we share that pattern of how we make it with others? I don't know the answer to that question yet, but yeah, that's a question worth asking. And again, it's having an instrument that's very user friendly. And you can hold it against your body, feel the vibrations, which feels really important as well. Yeah.
Thank
Great
you, ma'am.
question.
Thank you.
Absolutely.
No, just say with the growth and the emergence of music therapy, it's so beautiful that there are many instrument makers who are
Yes.
basically making specific instruments
Yes.
for the therapy. We also brought some to the institute, and I think after lunch we're not going to sleep, but we listen to some instruments.
Lovely.
I had
Wonderful.
one specific question. I'm sorry, I missed that.
Oh, no, it's okay.
The definition of delirium. What is this?
Yes. So it's really an acute state of confusion. Yep.
That means it's complex. It's bringing all the situation together, the mental state,
Yes.
physical state. It brings all those elements.
Exactly. So, and it's very distressing. So it's you can't, so oftentimes people, I can talk more specifically about people who are mechanically ventilated because that's where I've done so much research. But as you could see from some of the literature, it's happening in so many other clinical settings. But when people are mechanically ventilated and they're sedated, their nights and days get mixed up. And because they're sedated, they don't have a clear sense of their surroundings, so the treatments we're using to manage the mechanical ventilation are then leading to delirium. So we need to look at other ways of managing these symptoms. Because if we're giving medication and the treatment itself is causing more complex, severe issues, Are we helping, or it's complicated. It's so very complicated. So yes, it's very tricky, but we know that once people begin to experience delirium, their likelihood of death drastically increases.
So it's kind of a combination between high stress and sedation and confusion.
It's and then even just within what's happening physically within the body, because someone could have an infection that could cause delirium as well. And it's part of the challenge of how do we address this, because there are so many underlying causes of delirium. And so I think part of it is that we have to look at this in each clinical setting in very different ways, because what's causing it, for mechanically ventilated patients might be very different than it is for someone who's had hip surgery, or someone who's had cardiac surgery, or someone with dementia. Yeah.
Yeah, it's already helpful that we have defined it and recognized it, no?
Yes.
Because it must have been there for years, but now actually we said this is it, this is the state.
Exactly. And then how do we detect it? How do we detect it earlier so that someone hasn't been experiencing it and we haven't even addressed it? So can we get to it sooner? Yeah, there's lots of significant things we need to be doing around this. Absolutely. But those are great, great questions.
Wonderful. Thanks a lot, Dr. Annie.